तो हेलो गाइस, आज का हमारा टॉपिक है रेटिनोब्लास्टोमा. ओके, फर्स्ट ऑफ ऑल लेट्स classify the intraocular tumors. Okay, intraocular tumors are classified into iris, okay, malignant melanoma of iris and nevus of the iris. For ciliary body, malignant melanoma of ciliary body. For choroid, nevus, melanocytoma, hemangioma, malignant melanoma. Okay, for retina it is retinoblastoma. Okay, so today we are going to see tumor of the retina, that is retinoblastoma. Okay, it is into genetics, pathology, clinical feature, differential diagnosis and management of the retinoblastoma. Okay, most common intraocular malignancy of childhood. Okay, it is retinoblastoma. Most common intraocular tumors of childhood. Okay, incidence is 2/3 before 2 years of age. And no racial predisposition, higher incidence in males, 1 in 2000 live births. Unilateral tumor presents within 1 year, bilateral between 2 to 3 years. Okay, so initially one eye will be affected, later both the eyes will be affected. Okay, and it is incidence will be more common within 2 years of life. Okay, and after 2 years it does not, it the incidence is rare. And there is no racial predisposition, means it is common in all the races. Okay, and it more predominantly seen in males. Now coming to the genetics. Okay, genetics, it is 30 to 40% it is bilateral condition. Okay, first one eye will be affected, later both eyes are affected. Unilateral in somatic mutation, bilateral in genetically determined by tumor suppressor gene. Okay, you already know retinoblastoma, you have read in pathology. Okay, associated with the deletion of Q14 band of chromosome number 13. Okay, tumor suppression gene retinoblastoma is not working, RB gene. Okay, 2/3 will be sporadic, 1/3 will be heritable. Okay, bilateral with affected parents 45%. Chances of sibling being affected without affected parents is 5%. 5% chance of sibling being affected. Okay, unilateral with normal parents less than 1% chance in siblings. Okay, this is genetics. Origin, tumor arises from premature cells of photoreceptors. Okay, premature cells of photoreceptor. What are photoreceptors? Rods and cones, usually multicentric origin. Okay, histopathology, there are two types, differentiated retinoblastoma, undifferentiated retinoblastoma. First, coming to differentiated retinoblastoma, we can see polygonal cells with darkly stained nuclei. Okay, polygonal like this type. Okay, polygonal cells with darkly stained nuclei, scanty cytoplasm. Most commonly we will see Flexner-Winsteiner rosettes and Homer-Wright rosettes and florets. Okay, these three are things you should remember. Flexner-Winsteiner rosettes, these are cells arranged in a circular manner or an empty space. Okay, Homer-Wright rosettes are cells arranged in circles. Central space contain filaments. Okay, lumen filled with eosinophilic material, matlab pinkish material. All also seen in neuroblastoma or cerebellar medulloblastoma. Next is florets. Okay, florets means composed of rods and cone inner segments and represents retinal differentiation. Okay, three things: Flexner-Winsteiner rosettes, Homer-Wright rosettes, florets. Okay, we can see in differentiated retinoblastoma. Next, coming to undifferentiated retinoblastoma, consists of anaplastic cells. Okay, what is anaplasia? You should know from pathology. Arranged in sheets. Okay, around lumen, blood vessels are pseudorosette. Mitotic figures are numerous. Cell necrosis is widespread. Okay, anaplasia means cell will lost its integrity and it will be of variable shape and size. Okay, but in differentiated it will be more commonly polygonal in size. Okay, we can see pseudorosette here. So first, seeing in the diagram, you can see Homer-Wright rosettes, you can see undifferentiated tumor cells, you can see Flexner-Winsteiner rosette. Okay, three things: undifferentiated tumor cells, Flexner-Winsteiner rosette, Homer-Wright rosettes. Now coming to the clinical picture of retinoblastoma, there are 4 stages. One is quiescent stage, glaucomata stage, extraocular extension, distant metastasis. Okay, quiescent, the word itself means silent. Okay, 6 months to 1 year it will be silent. Next there will be leukocoria, that is amaurotic cat eyes. Okay, the mother will take and come the child with a whitish discoloration of the eye. Okay, means like white color, leukocoria will be seen. Okay, squint, usually convergent squint. Okay, the tumor presses the eye, therefore the eye will move. The eye will, like the boy is seeing the nose. Okay, convergent squint is seen, that is esotropia. Defective vision, early child is old enough, they can complain. Okay, they can complain there is eye pain. Ophthalmic features are ophthalmoscopic features are endophytum, growth inside the retina. Okay, well circumcised polypoidal mass, blood vessels and hemorrhage over the mass. Okay, it is endophytum. Growth can be two. Okay, one is endophytic growth and one is exophytic growth. Endophytic growth inside the retina, it is well circumcised polypoidal mass with blood vessel and hemorrhage. And exophytic growth, exophytic means you already know exophyte, something is growing outside, grows outwards, spreads retina from choroid. Okay, Resembles exudative detachment. You already know retinal detachment, three types. With ultrasonography, it can be differentiated from exudative detachment. Okay. Next stage will be glaucomata stage. After coesequent stage, we will get glaucomata stage. Coesequent stage left untreated, pain, redness, and watering. Signs are eyeball is enlarged and proptosis seen. Intraocular pressure is raised. Cornea looks hazy. Resembles acute uveitis. Okay. Pseudohypopyon or hypomania may be seen. Glaucomata stage means glaucoma type conditions are the uveitis stage, increased intraocular pressure. Next is the stage of extraocular extension. Okay, tumor comes out of the eyeball by bursting sclera. Extraocular tissues involve rapid fungation and marked proptosis. Okay, the tumor will come out of the sclera and it is visible to everyone. Stage of distant metastasis means it will spread to other tissues by the lymphatic spread and direct extension. Lymphatic spread is by preauricular lymph nodes and neighboring lymph nodes. Okay, direct extension is by optic nerve to the brain. Brainstem extension to the cranial bones and other bones and other organs like liver and lungs, etc. Okay, four stages are there. First is coesequent stage. Next is a glaucomata stage. Next is extraocular extension. Next is distant metastasis. Okay. International classification: retinoblastoma is classified based on the tumor size, location, and seeding. Okay. Group A, B, C, D, E. A is up to 3 mm in size. B is greater than 3 mm with macular location, subretinal fluid surrounding it. C is with localized seeds. D is with diffuse seeds. E is massive tumor needing enucleation of the eye. Okay. Differential diagnosis between glioma and pseudoglioma. Okay. Leukocoria means pseudoglioma. First, we will see intraocular pressure is raised in glioma and decreased or normal in pseudoglioma. Eyeball size increased or normal in glioma, decreased in pseudoglioma. X-ray finding is enlarged optic foramen calcification. Here, normal optic foramen and no calcification. So, progression glioma is progressive. Pseudoglioma is usually non-progressive. Okay, glioma you already know glial cells. Okay, tumor of the glial cells. That's why the optic nerve is enlarged here. Causes of leukocoria, one of the important viva question also. Retinopathy of prematurity, that is retrolental fibroplasia. Persistent hyperplastic primary vitreous. Cyclitic membrane. Endophthalmitis. Exudative retinopathy of Coats, that is Coats disease. Coloboma of choroid and congenital cataract. Okay, most commonly you remember congenital cataract, it is very much easy, and endophthalmitis is also easy, and retinopathy of prematurity. Okay, these three you can remember. Coloboma of choroid is also easy. Next, first coming to retinopathy of prematurity, it is a bilateral proliferative retinopathy of premature, less than 32 weeks of gestation. Okay, premature child, baby with low birth weight, that is less than 1500 gram, with a history of prolonged exposure to oxygen. There are 5 stages, stage 1, 2, 3, 4, 5. Stage 1, flat demarcation line separating vascular and avascular retina. No treatment required, only observation is required. Stage 2, rigid demarcation line. No treatment required, only observation. Stage 3, fibrovascular proliferation. Laser photocoagulation or cryotherapy is needed. Next is subretinal detachment. Surgery is needed. Total retinal detachment, surgery is needed. Okay. First is retinopathy of prematurity. It is a proliferative retinopathy of premature, less than 32 weeks. Okay. There is a line of demarcation between vascular and avascularization zone. That line will become more prominent, then fibrovascular proliferation, then retinal detachment occurs. Based on that, there are treatment modalities. Okay, you can see that. Persistent hyperplastic primary vitreous. Okay, it is a developmental disorder of the vitreous, usually unilateral, associated with microphthalmos. Means vitreous fluid is not developed. That's why eye will shrink. That is microphthalmos. Okay, cyclitic membrane. It is a fibrosis of plastic exudates behind the lens. Okay. Seen in acute plastic iridocyclitis, coagulation of exudates on ciliary process destroys its function, usually due to toxocariasis. Endophthalmitis, you already know, it is one of the most common dreaded complication. Okay, eye enucleation is seen. Inflammation of internal structure of the eye with choroid, retina, and vitreous. Okay, exudative retinopathy of Coats, that is Coats disease. Choroid of coloboma, congenital cataract, usually unilateral, bilateral. Okay, these are differential diagnosis of leukocoria. Actually, I need not to explain this. But you already know, you can remember better. Retinopathy of prematurity, congenital glaucoma, persistent hyperplastic primary vitreous, coloboma of choroid, congenital cataract. Now coming to the diagnosis of retinoblastoma. First, why you need to be diagnosis? Okay, it also helps in differentiating other differential diagnosis. Okay, examination under anesthesia, we will do fundus examination, then we will measure corneal diameter and intraocular pressure. Okay, we will take plain X-ray, calcification 75% of the cases is seen. Next, we will do lactic dehydrogenase enzyme. Level is increased in aqueous tumor. Okay. Ultrasonography B scan, we can see a very beautiful tumor. Next, CT scan, optic nerve extension, orbital spread, and CNS spread. Okay, these are the complications. Next, treatment modality retinoblastoma. Treatment: focal therapy, argon laser photocoagulation for tumors greater than 3 mm, cryotherapy for anterior tumors, and transpupillary thermography, large spot diode laser, normal tissue spared. Okay, transpupillary thermography, either we will use laser, either we will use cold, either we will use heat. Okay, cold, heat, laser. Local therapy will do radiation. Okay, plaque brachytherapy for too large for focal therapy. Next for away from disc or macula. Next we will use external beam radiotherapy for extensive vitreous seeding. Next, final thing is to be enucleation. Okay, large unilateral tumor occupying more than half of the globe, 10 to 15 mm optic nerve to be cut to test the intracranial spread. Okay, you should take little more amount of optic nerve. Okay, 10 to 15 mm, like more than 1 centimeter, so that to prevent CNS spread. Okay, systemic chemotherapy for bilateral tumors. We will use VEC, that is vincristine, etoposide, and carboplatin. Okay, VEC, vincristine, etoposide, and carboplatin. If in unilateral tumor, to reduce the size of the tumor and later treated with focal therapy. If optic nerve is involved, okay, sometimes optic nerve may get involved. After enucleation, radiotherapy we will give, that is 500 rats after, applied to the orbital apex. Okay, and periodical review for look any reoccurrence. We will give palliative therapy is to be given for retinoblastoma with orbital extension, intracranial extension, and distant metastasis. Okay, palliative treatment, supportive treatment. Palliative treatment is combination of chemotherapy, debulking of the orbit or orbital extension. We will do EBRT, that is external beam radiotherapy. Okay. This is the treatment for optic nerve is involved. This is the treatment for this is retinoblastoma. Okay. Focal therapy we will use laser, cold or heat. Local therapy we will use radiation, and final thing will be enucleation along with systemic chemotherapy. Okay, that's it. This is retinoblastoma. See you in the next video. Until then, Jai Hind, Jai Bharat.